level. Okay, moving on to Henry Katamba from the Ministry of Health, Uganda. And just to stress that our objective was not to be Uganda focused, but we had invited somebody from Ministry of Health Nigeria, where ICCM will soon be implemented, and unfortunately he couldn't make it because of a visa hitch. Over to you. And Zambia as well, another visa hitch, sorry.
Okay. Thank you very much. My task this morning is to create context around ICCM in Uganda and also stimulate debate about the role of ICCM, especially in the areas that we are going to be going into in regard to the control of malaria and other diseases like pneumonia and diarrhea diseases. Currently, 42% of children under 5, you will find them with the malaria parasite. It's about 1 in every 2 children you'll find in Uganda. And there are quite a number of interventions. There's been a lot of investment. But despite that investment, what are the other areas that we can look into that are simple to apply, community-based, and are more cost-effective? And that is where ICCM comes into context. We have about 144,000 children dying by the age of 5 years. 40% of these deaths are caused by pneumonia, malaria, and diarrhea diseases. That translates into about 56,400 deaths per year among the under 5s. And the picture that is before you is a typical pediatric ward. But this one actually portrays the picture of the non-high transmission months. Very often, you find even the floor is covered with mattresses and clients when it is the high transmission month. The aim of integrated community case management is to improve correct use of life-saving treatments by making them available, ensuring their delivery, ensuring quality, and mobilizing demand for them at the community level. The main target in the first 28 days is the identification of the danger signs and appropriate referral. From 2 months to 60, from the 2 months to 59 months, that's 5 years and below. Diagnosis and treatment of malaria, pneumonia, and diarrhea diseases at the community level is what is very, very important under the ICCM. The main objectives of the programs is to have at least 80% of the under 5s with non-severe disease receiving appropriate treatment within the first 24 hours of onset of illness. 80% of the severe diseases promptly and correctly referred to the formal providers, and this includes the newborn who have shown the danger signs. We would like to also see 80% of the village health team members who correctly manage simple cases of malaria, pneumonia, and diarrhea diseases. At least 60% of these VHTs should have zero stockout rates for the first line medicines. Suspected malaria cases should be tested with RDTs, and this should actually move from the current 5% to at least 80%. And again, this is to emphasize rational drug use, because not all fevers are actually presenting with malaria, but we are having a lot of cases that are treated with ACTs only on suspicion of malaria. Then confirmed cases treated with ACTs should increase from the current 10% to 80%. acute malnutrition identified and referred for therapeutic feeding. Those are some of the objectives that we look out to achieve using this approach. Now, in ICCM, quite a number of areas are of concern, and one of them is the coordination. And under this, we have a number of areas that need to be addressed, and most of them have been addressed actually. It is the scaling that is very important. Under capacity building, I think from previous slides, we've seen what has been developed in terms of adapting materials, the issues related to training of supervisors, involvement of the health facilities, and the linkage with the village health team and their home visits with the newborn children. Advocacy and sensitization being coordinated by the National Task Force. We have one in place, which is also involved in mobilization of resources, although it has its challenges, as we shall be discussing. Issues related with commodity security at the different levels of the supply chain. The drugs and the diagnostics are also some of the things that need to be looked into. Supervision and monitoring, and here I think we've heard about the areas related to competence, which is being addressed through training. Indicators have been developed, both at the facility and more so at the community level, and also innovative methods of transmitting data and information using mobile telephony have also been explored. Evaluation and research, there are result frameworks that have been developed, and also some reviews have been done in the area of ICCM, and things related to cost equity and cost effectiveness and the impact of ICCM on some of the different interventions are some of the areas that have been explored, although at a minimum level. And we require to, it's very important for us to use whatever we have generated, especially these findings, to see how we can influence policy and implementation of the current policy at the national level. Probably we would like to also clarify the concept of the village health team and their role in the healthcare. The village health team is a national concept, and these are chosen from the community, and quite a number of things are taken into consideration in selection of a village health team member. Their ability to read, their ability to write, issues of gender are also addressed, and in a village which normally has approximately 30 to 50 households, is normally manned by 4 to 5 village health team members. And of these, at least a third have to be women. Their role is mainly identifying danger signs and referral of newborn children, treatment of malaria, pneumonia, and diarrhea. And here it is very, very important to also note that it's not just treatment, but also diagnosis. And the whole aspect of introducing rapid diagnostic tests in malaria were all related about making sure that diagnosis takes place at the community level. And also the training component of the VHT emphasizes basic health promotion. And in regard to ICCM, it's a hands-on training based on the sick child job aid and register, and also use of the respiratory timers and rapid diagnostic tests, as the previous presentation alluded to. And it's very important to note that in Uganda, non-monetary incentives are used to motivate the village health team members. For example, bicycles, t-shirts, badges, and other methods. They have a package, and this includes medicines. And I think our previous president has talked about the color codes that make it very simple for them to identify the dosages that are targeted for under 5s. Diagnostics, that includes the mid-upper arm circumference, the respiratory timers, and the rapid diagnostic tests for malaria. And there are job aids also for the sick child. Patient registers, these are simple. They've been really made simple for the VHTs. And in some areas, the mobile telephony, we call it the M-Track system, in which they transmit information to a central database using their function of the SMS. But the cost does not come to the person sending. The cost comes to the Ministry of Health. And those are some of the things that have been used to monitor cases treated, the drug stock status, and also consumption of diagnostic tests that will have been shared with them. This map shows the different partners that are involved in ICCM in Uganda. And the one in green actually shows the districts that are covered by Malaria Consortium and ICCM. And it's also important for us to emphasize that these are high transmission districts. The implementation of ICCM has gone through a number of phases, and it took about 15 months to introduce. And early implementation was initially in 20 districts, and at that time, Uganda had 80 districts. So that constituted about 25% of the districts in Uganda. They had introduced ICCM. These were expanded to 34 districts, and Uganda also had a policy of increasing the number of districts. And you can see from 80 districts, by the time ICCM was expanded to 34, Uganda had 112 districts. This included fragmentation of the original 80 districts. So right now we are talking of parent districts and new districts, and all of them are at different levels of implementation of ICCM and many other interventions. The new districts, which are young, are often characterized by lack of trained personnel. They are rather rural, and primarily that is why they were made districts, so that investment could actually focus on the challenges that they specifically have. And it is very difficult to actually attract skilled health workers. And that also now brings the issue of having very good innovative methods of using the community in the interventions, the different interventions that we are making. And right now, there is a review of what we have had to see how we can now inform policy and subsequent rollout. ICCM has evolved from other interventions, and it has applied best practices and lessons from the application of the home-based management of fevers. And also there was a pilot on the use of antibiotics among internally displaced people. There was a drug policy review that is for pneumonia and diarrhea. And it has involved adaptation of generic WHO training materials. It has involved UNICEF as among the implementing partners, and has also defined the different levels of development, especially the implementation guidelines. What are the lessons learned from the early implementation? The districts are different stages of establishing the village health team systems, and yet the VHTs are the drivers of implementation of ICCM. There are two basic trainings, and each is a continuation of the other. It's hands-on, that is ICCM. It also uses principles of good planning, and coordination is also important, especially where you have multiple players, new districts and villages, and new partners. It is very critical for security of commodities, especially when you're using VHTs at community level. Motivation, especially when you're using non-monetary incentives. Issues related with sustainability, that is government picking up more of the investments in the expansion phase. And also the partnership with health facilities right from the start. The integration in the health system and mobilization of resources. The areas where we've tried as government to strengthen ICCM, the current round 10 Global Fund grant under malaria took into consideration the availability of rapid diagnostic tests and ACTs at the village health team level. National Medical Stores has expanded the supply chain to the community level, although it's still having its challenges. And we are having program reviews for advocacy and also involvement of the private sector. And also we have looked at strengthening the link between health facilities and the community through quality improvement models and also introducing specific pages for VHTs in the mother-child health passport. We have had a number of constraints, and that includes mainstream medicine distribution in the national system, especially at the community level. The link between the VHT and the health facilities, especially in the routine data collection under the health management information system. Integration of ICCM in the district structure, health facility staffing, and continuous improvement of the VHT skills. And newborn component lagging behind. That is little information on this and more demand from the districts. Coordination of the different partners involved in ICCM. However, this is taking place under a number of opportunities. I talked about the Global Fund. There is also the global focus on diarrhea and pneumonia opportunities, such as the UN Commission for Life-Saving Commodities. The current review can actually inform policy and also opportunities for learning from early implementation to feed the next phase of ICCM implementation. We would like to thank the number of partners who have supported us up to this level, and I would like to stop at this level and probably take on questions and areas of clarification. Thank you.
Thank you very much for that, Henry. And just to stress that Henry is representing the Director General of Health, Ministry of Health in Uganda. Okay, questions from the chat room?
Question from Boy Betty Udom at WHO. How is the management of stocks for commodities, RDTs and ACTs in particular, handled at the community level, and what has been experienced with stockouts?
Okay. Yeah.
Okay. Yeah. Management of stocks at the community level. First of all, the supply chain follows the facilities. When RDTs and ACTs come at the national level, there are two main areas that actually receive them. We have the national medical stores and the joint medical stores. These have a system of identifying consumption at the facility level and replenishing that stock through a distribution mechanism. Now, the village health team is attached to facilities, and any quantification of consumption takes into consideration the consumption of the VHTs. They have periodic feedback meetings, which are used to quantify how much has been consumed per VHT and how much has remained in balance. And that is what is used to estimate what to give a VHT over a specific period of time. And there are tools that have been developed that can track stock status of both the ACTs and RDTs with the VHTs. However, this requires a lot of investment in capacity building for the VHTs. And one of the biggest funder, the Global Fund, has actually changed strategy from giving a holistic package, including capacity building, to actually stock. And that is where the entire discussion has to be. Who is going to pick up the tab on capacity building? So that's where the dynamics of expansion are having challenges. Thank you.
All right, any question from the crowd? Yes.
Thank you for that presentation. Just to link back to the first presentation of Helen's, which talked also about behaviour change communication as part of a package of ICCM and the importance of radio programmes, of community dialogues. And I wondered how important you thought that was when you're looking at scale up, if you see that as part of a package of ICCM.
Yes, Henry? Henry, over to you. About community dialogues and how important you see that in the package for community health workers, VHTs.
Thank you. When I heard it's coming from a different slide, I'd kind of started taking note of other things.
Okay.
The importance of community dialogue. I want to say that when we are talking about service delivery at the community level, feedback becomes very, very important. And the aspect of community dialogue pulls on the skill set that we have picked to be the front runners, that is the village health team members, and also the kind of package, information package, that we equip them with for them to be able to give correct and consistent information to the community, for them to be able to make the correct decision and also be guided on how to benefit well from the management at community level. So what we have tried to do is to use the quarterly meetings that take place between designated facilities, the health workers of a designated facility and the VHTs, to one, get feedback of what is coming out from the community, frequently asked questions. Two, provide standard answers that are backed by the national policy guidelines for the VHTs in a very simple way. And three, identify areas where a VHT will require more support. And those are some of the things that we see can help in improving the quality of information that goes at the household level.
Okay. Sylvia, who else had a question? Oh, it's quite a number. All right, Sylvia first. We'll have to go for lunch very shortly. We're already 5 minutes late.
Okay, it was just to say, I get the impression that Uganda is probably one of the countries that's most advanced in its development of ICCM approach and strategy, and has learnt a lot and has really put a lot of ministry support behind it. And yet still there's this big cloud hanging over of commodity security and drug security. And you mentioned Global Fund in terms of anti-malarials and RDTs, but it still gives the impression of being rather fragile. And I noticed even your targets for zero stockouts was only 60%. I mean, how optimistic are you that that it really is going to be sustainable over the next few years?
Okay, Henry?
Yes, thank you very much. We're talking about sustainability. I would like to shed some more light on that. One of the slides talked about where we started from, 25% of the districts, and we're able to expand to 34% of the districts. I want to say that all this investment is largely donor funding. And what the country had actually done was to use the opportunity of the funding mechanisms, new funding mechanisms that had come into the country. And the entire design of the Round 10 malaria grant was around functionality of the ICCM with ACTs and adequate stocks of RDTs. And we drew lessons from what we had observed, especially in regard to tracking of the commodity from the community level. The tools that were being used, the level of supervision that was being done, and the capacity building that was required. All that was put into the Round 10 Global Fund grant. And we have moved 1 year into implementation. However, when we go back to sustainability, in regard to availability of stock, we have a guarantee of 5 years, at least in regard to the Round 10 malaria grant. However, the challenge comes in the area of capacity building. There is a need for investment in training of these village health team members and also close monitoring, especially the first 3 to 5 months of initiation of a district. Now, that is the level of investment that has actually been altered after the Global Fund adapted to 100% commoditization of the grants, meaning that we have more of the ACTs, we have more of the RDTs, but we do not have a partner who is actually funding the training and close monitoring of the VHTs. So in regard to sustainability, we have that specific challenge as a country. And this takes place at a time when all the other partners had already concluded on the areas they will have to invest in. They had, in regard to avoiding duplication of activities, they had not planned for investment into capacity building to expand ICCM. So this has to be clarified, that the sustainability is dependent on investment in capacity building for the VHTs and mentoring at the community level. And without that, all the gains that we have been able to demonstrate will be at a risk of being lost.
Okay, the lady from PSI.
Thanks. Thanks for asking that question, because that was exactly what I wanted to ask. But I wanted to kind of explore it a bit further, because again, you've talked about the sustainability of capacity building and mentoring and the commodities for malaria. But what about for pneumonia? What about the ORS and the zinc? All of that that's in your plan that won't be funded by the Global Fund. And where are we right now with regards to the program that the Malaria Consortium has been running, with the CEDA funding ending in 2012, as I understand it? What's happening right now? Is there a stock out?
Okay. Henry, and then...
Yes, I want to say that ICCM provides a very good opportunity for integrated management of diseases, especially those ones affecting under 5s. And we have a complete task force that deals with all the 3 conditions: diarrheal diseases, pneumonia, and malaria. And you will realize that diarrheal diseases and pneumonia do not have a specific program that actually does what? That focuses on them. But under the maternal and child health department in the ministry, we have made sure that the essential, the list of essential drugs, the drugs for diarrheal diseases and pneumonia are very well catered for. However, the aspect of the community, they are also getting a challenge of transiting from the facility-based service delivery to the community-based service delivery. And that is where we are having an entire discussion for all the three conditions.
Okay. Helen, do you want to say anything about CEDA? Yeah. Mike, yeah.
Yeah, maybe just to mention, as you said, CEDA funding finished, in fact, at the end of March this year, but we had commodities beyond the duration of the project. They're carrying on. We have more funds in Uganda specifically for later this year. We also have other funding to continue the implementation. But I'd like to also make the observation, yes, I think it's a big issue, but it also takes time for a government to commit, even if they identify where they're going to get the funds from. The fiscal planning has to be done at least 1 year in advance, especially if you're doing bulk procurement of these kind of commodities. So this is something that has a long lead time. That's why we're continuing to support as much as we can. Yeah.
Okay, just one question from the chat room, one question from Save the Children, and that's we go for lunch. Just one. Okay.
Question from Jorgen Stajin, the MSF. Could you give us an idea how high the workload of the VHT is? If high, do you think that non-financial incentives are still sufficient to motivate the VHT? And have you considered financial incentives?
All right. Okay, Henry, and then I don't know, Geoffrey, you will talk about workload at some point. Okay, Henry.
Yes. Ideally, each village health team member is in charge of 10 households. And on average, a Ugandan household has six people. And the biggest proportion of the population is actually 15 years and below. So we have a very big proportion of the household that you will find 5 years and below. So on average, I should say that a VHT is kept busy by about 20 clients in their area of jurisdiction. And I will talk about workload in terms of the bouts of malaria. Okay? Apparently, upper respiratory tract infections are more frequent than the bouts of malaria. In a month, during the high transmission months, you may get approximately 2 bouts of malaria per household. So that can be used to estimate the workload of a VHT. However, I would also like to contextualize it, because the VHTs, the approach has been designed for early detection, okay, and also diagnosis, give the drug and refer. Meaning that in 1 week, they will be expected to visit once or twice in problem facilities. Thank you.
Okay, on that note, one question from Save the Children, and we go for lunch.
Thanks, Doctor, for a very informative overview. I think Uganda is one of the countries that has some of the best policies in sub-Saharan Africa, and Uganda piloted CCM for the first time in East African community. I think there has been a big gap in terms of implementation or scale-up nationwide. Countries like Rwanda adopted the Ugandan model and scaled it up nationwide, whereas we're still struggling with some of the issues in Uganda. And I think you did point out a number of challenges. Some of the issues that still probably need to be highlighted are, I mean, things like credit line agreements exist between the national medical stores and the districts, but they don't work. Things like supervision, supportive supervision need to be implemented, but that doesn't happen. Meetings are not attended by the ministries because of sitting allowances. Abuja targets are not met because the ministry has not allocated sufficient funding at the current rate of progress, I think Uganda is not going to meet its MDG 4 targets for the next 25 years. CHWs are not remunerated. So even Uganda has a VHTs is level 1, health center 1. Not many other countries in sub-Saharan Africa have that. So I think village health workers or community health workers need to be remunerated. They need to be part of the primary healthcare system. They're not linked with the local government structures, with the sub-county structures, or with the councillors in the communities. There are lots of issues in terms of integrating CCM within the primary healthcare system, and I think the government knows that, the policies say that. It's just about implementing them.
Okay, Henry, you have the final word?
Yes, it's very, very correct. You've raised a lot of clarity on the situation in Uganda. And again, that also underscores the importance of investment, especially where are you going to focus your investment? Are you going to continue at the facility level, or are we going to look at making sure that we functionalize investment at the community level? And we believe that with the current interventions, we expect to achieve, for example, universal coverage with long-lasting insecticide-treated nets within the first 2 months of 2014. Now, given those interventions, what are some of the things that we can actually build on to focus investment into areas that are going to cause change? And that is where we see that if we actually build on what we have gained with ICCM, we should be able to create change beyond what we are seeing currently. Currently, you're very right. Most of the investment has been to operationalize the facility, the health facility level. But we have seen that where we have reached in our interventions, we should now look at ways of functionalizing the community level and linking it to the current health management information system. And that is where we have our challenges, despite all the other challenges that we are seeing. That's what I can say for now.
All right, thank you very much. I'd like to say it's now about 5 minutes past 1. We should have lunch for 40 minutes and then we're back. Just to stress to the colleagues and friends who are online that they should please come back in 45 minutes because we have some more exciting presentations in the afternoon and a hopefully very exciting panel discussion. So please, you're invited for lunch and then back in 40 minutes. Thank you.